G?
Game? Kompleto na tayo?
Okay.
Dr. Del Rio.
Sunod daw, Dr. Del Rio.
Sige, game na.
Okay. Good evening, everybody. So for today's lecture, I will be discussing the surgical conduct of ureteral reconstruction. So for the objectives of this lecture, first I will detail the basic principles in the surgery of ureteral reconstruction, and then I will explain in detail the following procedures. 1, ureterostomy. Number 2, ureteroneocystostomy and the different techniques. And then psoas, hitch, and Boari flap. In the process of detailing those procedures, I will also detail the postoperative course and care for patients undergoing the said procedures. The sources for my lecture are, of course, Campbell, 12th edition, and Hinman's Atlas of Urologic Surgery, 4th edition. So first, for the general principles, as was discussed by Dr. Yadaw's trauma lecture a few weeks ago, the site of injury will dictate what type of surgery the patient will undergo. So for injuries to the upper third ureter, the surgeries that can be applied to that injury will be direct ureterostomy or transureterostomy. The same can be said for the middle ureter. For the lower third of the ureter, reimplantation or ureteroneocystostomy is warranted, as well as the psoas hitch. As was detailed in Campbell, ureteral reconstruction has general principles that will be followed in all of those surgeries. So first, careful mobilization of the ureter with wide sparing of the adventitia. Next is minimal but judicious derima of the ureter. Third is repair ureters with spatulated, tension-free, stented, and watertight anastomosis using fine absorbable sutures with retroperitoneal drainage. Fourth is to retroperitonealize the ureteral repair. Fifth is to create a widely spatulated, non-tunneled anastomosis. Sixth is to consider omental interposition for severely injured ureters. Now, if immediate repair is not feasible, we have the following options. We can ligate the ureter with silk or propylene suture with the intent to come back later for a later repair. Second is to place a nephrostomy tube. Third is to stent the ureter and then suture the stent proximal to the injury. We can also identify what type of surgery is appropriate for the patient depending on the defect of the ureter injury or stricture. So for ureterostomy, the usual defect, length of the defect for those cases are defects 2 to 3 centimeters in length. For ureteroneocystostomy, for 4 to 5 centimeters. For psoas hitch, 6 to 10 centimeters. And for the Boari flap, 12 to 15 centimeters. Okay, so first I will be discussing ureterostomy. UU is also termed as an end-to-end repair. It is used in acute injuries and short defects in the upper 2/3 of the ureter. The success rate of the procedure is approximately 90%, and the most common acute complication is urine leakage, followed by abscesses or fistulae. The chronic complication for UU is ureteral stenosis, which occurs in 12% of cases. Now, preoperatively, for patients who will be undergoing UU, in cases of patients who will be undergoing UU for strictures, in patients with stents, allow for 6 weeks of ureteral rest. Afterwards, remove the stent but perform percutaneous nephrostomy tube placement. And now, for the preoperative consideration, of course, if the surgery is an elective surgery, we should always perform adequate preoperative preparation, do a blood count and serum chemistry, secure the blood products, preoperative imaging, CT scan, for example, or CT urography for a stricture. However, in cases of an emergency procedure for trauma, IVP and direct visualization will provide sufficient for doing a UU. The goal of which in doing IVP or direct visualization, IVP in the emergency setting is to evaluate the contralateral urinary tract. Now, for the surgical incision depends on the level of the pathology. So The midline vertical incision will be applicable to any portion of the ureter from the middle, from the upper, the middle, and the distal. The subcostal or flank incision is for the proximal third of the ureter. The Gibson for the mid to the low or the lower ureter, and the fan and steel incision is for patients who have undergone previous surgery with the fan and steel incision, and with the option to extend the fan and steel incision cephalad in a hockey stick formation. So after the incision, we are to continue the dissection until the retroperitoneum is accessed. And afterwards, you sweep the peritoneal contents medially to expose the following: the psoas muscle and tendon, the iliac vessels, and the gonadal vessels. To identify the ureter, the ureter is usually in the soft tissue anterior to the bifurcation of the common iliac artery. And it courses posterior to the gonadal vessels distally. So once you have identified a structure which you think is the ureter, to confirm that it is indeed the ureter, we have two ways. So first is to inject diluted methylene blue, specifically 2 cc of methylene blue in 50 cc of plain NSS, and inject it through the aforementioned NT tube and aspirate it from your suspected tubular structure to be the ureter. Or you can also perform a gentle squeezing of the ureter, which should elicit a ureteral peristalsis if it is indeed the ureter. What we should watch out for in doing this maneuver, however, is if it is on the iliac vessels, it can lead to intimal disruption and thrombosis. So you better be sure if you're going to perform palpation or squeezing of that tubular structure. Once identified, you place a vessel loop around the ureter. Okay, so these are intraoperative pictures of during ureter identification. So as you can see on the picture on the left, this was done with a Gibson incision, and on the right, the ureter is exposed after reflecting the cecum and ascending colon with a thick rind encasing the ureter, which is typical in patients with radiation-related fibrosis and stricturing. Additional considerations for the ureter: ureteral pathologies above the level of the pelvic brim will require medial mobilization of the colon and identification of the ureter in the tail of Gerota's fascia, posterior to the gonadal vessels. So when locating the ureter, it is usually posterolateral to the gonadal vessels proximally and posterior medial to the gonadal vessels once you reach the middle and the distal ureter. So once you have identified the ureter, you look for the site of obstruction or trauma or injury. You debride the non-viable tissue, and then you mobilize the ureter proximally and distally to allow for a tension-free anastomosis. Important to know, however, is for injuries caused by high-velocity gunshot wounds, for gunshots with more than 2,000 feet per second, they are associated with a larger zone of devitalized tissue. Also, during mobilization of the ureter, care should be taken to preserve ureteral adventitia. And if there is still tension despite mobilization, best to prepare for another procedure such as the psoas hitch or a bladder flap. Once we have transected the injured part, we can perform ureteroscopy proximally and distally to confirm the absence of any other pathologies for the length of the ureter. The proximal and the distal ends of the ureter are then widely spatulated, and then end-to-end anastomosis is performed using a fine absorbable suture. Important to note also, before performing the actual anastomosis, the break of the table should be taken out to reduce tension on the anastomosis. So here, along with its accompanying picture, the spatulation is performed on opposite sides. The unspatulated end of one ureteral end is then sewn to the spatulation on the other end. In cases where there is grossly dilated, when there is a grossly dilated ureter involved, an oblique transection may be performed to match the non-dilated circumference of the non-dilated segment. So anastomosis may be done with interrupted sutures or with a running suture. And the knots of your suture may be placed intraluminally or extraluminally. In performing the anastomosis, the considerations in performing an interrupted versus running suture is if the tissue quality is tenuous, an interrupted anastomosis allows for a more precise closure and ensures that the entire repair is not in jeopardy if a single area becomes compromised because poor tissue quality or inadequate bite during suturing. So I guess for our level, best to do the anastomosis with interrupted sutures. Next, after the posterior anastomosis is complete, a ureteral stent is placed, followed by the anterior anastomosis. Tissue wrap is then applied, which can be omental or peritoneal, and a closed suction drain is placed adjacent to the anastomosis. The nephrostomy tube is then clamped, not removed, and left in place. Now, the transureterostomy falls under ureterostomy, but it is with a different technique. So it is performed in patients with long segment, mid to distal ureteral strictures and limited pelvic access, not allowing for ureterostomy with a psoas hitch or a bladder flap. The transureterostomy should be avoided for patients with a history of urothelial malignancy, those with urolithiasis that may require future upper tract procedures, and those with bilateral ureteral strictures. So in this case, midline vertical incision is done on the up to the xiphoid process, allowing for adequate proximal mobilization of the ureter for transposition across the retroperitoneum to the other side to the contralateral ureter. The line of thought is then incised lateral to the colon and ureter, and the ureter is identified in the retroperitoneum. Subsequently, the site of pathology can then be identified. So here, a midline incision up to the xiphoid process, and over here, you pass the ureter to the contralateral side for anastomosis. So, incision of the ureter proximal to the pathology, and the stay suture is then placed. Again, ureteroscopy may be done to exclude a more proximal pathology. The ureter is then mobilized 10 to cm proximally, and a tunnel is created in the retroperitoneum posterior to the mesentery of the small bowel, and importantly, cephalad to the inferior mesenteric artery. If there is enough ureteral length that the ureter can be readily passed caudal to the IMA across the midline, then you can perform a ureteroneocystostomy instead of a transureterouterostomy. So the recipient ureter is then mobilized at the recipient site or on the contralateral side and incised on its medial side. An end-to-side anastomosis is then performed using interrupted or continuous sutures using 5-0 polyglactin or Vicryl sutures. Then a stent is placed across the anastomosis, like the UU tissue wrap is applied, a closed suction drain is placed, and the NT is clamped and left in place. For the postoperative care for both ureterostomy and transureterostomy, IFC is removed on the first operative day. The drain is removed prior to discharge, which can be on the fourth to fifth day. And in case of a urine leak, a plain abdominal radiograph to ensure that the distal end of the stent is adequately placed in the bladder and the drain is not directly on the anastomosis. Almost all urine leaks cease with conservative management. With conservative management, continuous drainage, replacing the IFC if clogged, and uncapping the nephrostomy tube. The early revision of the anastomosis is really necessary unless the total anastomotic disruption manifests as massive urine leak despite conservative management. So, after discharge, an antegrade nephrostogram is done on the still intact nephrostomy tube 46 weeks after the surgery. If the antegrade nephrostogram looks unremarkable, you can then perform stent removal. And in the interim, if the patient experiences renal colic, you can then unclamp the nephrostomy tube. A week after the stent removal, a repeat nephrostogram is done. And if there are no leaks, the unremarkable study, you can remove the nephrostogram. 1 month after removing the nephrostomy tube, you ask the patient to follow up for renal ultrasound, and then afterwards you can remove all. And then, you know. Okay. Now for ureteroneocystostomy. So ureteroneocystostomy is for ureteral defects measuring 3 to 5 centimeters in the distal ureter. It can be performed open or laparoscopically. And aside from injuries and strictures, this procedure is also the primary surgical management for vesicoureteral reflux and primary obstructive megaureter, which is more commonly found in the pediatric population. It is also performed in renal transplantation. So considerations, again, careful handling of the ureter to avoid injury and the vascularization, adequate mobilization of the ureter for tension-free anastomosis. This is very important though, 5:1 ratio of submucosal diameter to ureteral diameter to avoid vesicoureteral reflux, and the avoidance of a kink, twist, or angulation in the ureter during anastomosis. So the patient is placed supine with a table break under the pelvis, and then a pan and steel incision is performed along the patient's Langer lines, 1 finger breadth above the symphysis pubis. After the incision, you develop the underlying tissue, incise carpus fascia, and expose the external oblique aponeurosis. So there we have the incision and development of the incision. And then you incise the anterior rectus abdominis sheath. You place a self-retaining retractor to retract the fascial flaps. And you incise the midline transversalis fascia. You then enter and develop the space of Retzius by retracting the rectus muscles. And then you have reached the bladder, after which you clear the bladder of perivesical fat. And then you stabilize the bladder and apply stay sutures. Once in the bladder, you perform a vertical cystostomy with electrocautery. You place chromic trio retraction sutures from the bladder through the full thickness of the anterior wall lateral to the caudal apex of the cystostomy to the skin or rectus fascia lateral to the midline. Subsequently, you then pack the bladder with wet sponges. So for the different ureteroneocystostomy techniques, okay. First, we'll discuss ureteral mobilization. So you intubate the affected ureter with a feeding tube and secure the adjacent bladder tissue with a silk 4O suture. You secure the bladder urothelium circumferentially around the ureteral orifice with electrocautery, leaving a rim of urothelium around the orifice. Then you begin sharp dissection of the ureter within Waldeyer sheath distal to the orifice. Okay, so see, you intubate the orifice, and then you score the bladder urothelium and you dissect. Oops, sorry. And you dissect around the ureter. So then you mobilize the ureter with traction on the feeding tube by dissecting the bladder muscle fibers away from the Waldeyer sheath using blunt and electrocautery dissection. You then dissect the extravesical ureter away from the adjacent peritoneum, and you must take note to carefully cauterize the small branches of the superior vesical artery along the peritoneal reflection. So you continue dissection of your ureter. Now you perform extraperitoneal blunt dissection of the extravesical ureter with a right angle clamp. You perform this by creating a plane between the posterior bladder wall and the anterior wall of the ureter. Then you make a transmural incision through the posterior bladder wall with electrocautery at the intended site of your neohiatus, or where your ureter will now enter into the bladder. You subsequently transfer the distal ureter to that neohiatus, and then you dissect a submucosal tunnel from the neohiatus to the original ureteral orifice using your tenotomy scissors. You close the overlying gap in that original hiatus with uninterrupted vehicle 2 suture. So here, picture A is you creating your neohiatus, and then you develop that neohiatus. Picture C is tunneling the neohiatus with the intent to bring your ureter up to the neohiatus. So you transfer the distal ureter through the dissected mucosal tunnel, and then you excise the most distal portion of your ureter. You then spatulate the distal part of that ureter sharply with tenotomy or pot scissors. And then you anchor the distal posterior ureter to the neohiatus with interrupted chromic 4-0 sutures at the following positions: the 5, the 6, and the 7 o'clock, approximating the transmural ureteral tissue and ureteral orifice. So, yan. Then you approximate the urothelium of the orifice to the spatulated ureter to the 12 o'clock position with the chromic 5-0 suture. And then you close the overlying urothelium over the hiatus with a running chromic 5-0 suture. Another technique is your ureteral advancement technique. It happens in cases when it is necessary to extend the length of the mucosal tunnel. It is done by creating a second submucosal tunnel, this time towards the bladder neck. So you begin by intubating the ureter with a feeding tube and passing it proximally to the hiatus to ensure that there is no obstruction. And then you perform the anastomosis after tunneling your ureter to the second submucosal tunnel, as was previously described in your ureteral ostomy. And then you also close the overlying urothelium with a chromic 5-0 suture. So here, like the previous one, the basic ureteral ostomy, you create a second submucosal tunnel after your ureteral orifice, and this is where you now position your new orifice more caudal to the original position of your orifice. Now, for the Transtrigonal or the Cohen technique, this is performed by mobilizing the ureter to be reimplanted to the other side or to the contralateral ureteral orifice, near the contralateral ureteral orifice. So create a submucosal tunnel sharply from the hiatus of the ureter to a point just cephalad to the contralateral ureteral orifice. And then you transfer your ureter through that submucosal tunnel, and then you perform the anastomosis in that new orifice. Ayan. So instead of positioning your new orifice caudal compared to the Cohen technique, this time you put it on the contralateral side there. It can be done bilaterally, but you perform it sequentially. You complete the anastomosis on one side first before starting on the other. As for the spatulated nipple technique, it is performed when bladder capacity is inadequate to create an effective tunnel length to ureteral diameter ratio despite ureteral tailoring. So you perform this by bringing approximately 2 cm of the ureter directly through the bladder. And then you fix the ureter to the neohiatus with simple interrupted chromic 4-0 sutures that approximate the ureteral tissue to the muscular bladder tissue. And then you spatulate that distal end and divert the distal ureteral lumen. And so 2 cm, and then you spatulate, and then you avert. You then approximate the distal ureteral margin to the bladder urothelium surrounding the original ureteral orifice with simple interrupted sutures, and then you reapproximate the spatulation now over the more proximal ureter with simple 5-0 or 6-0 sutures. And then you intubate it with a feeding tube. So after I've discussed those techniques, when do we perform, okay, so the choice of transvesical technique is dictated by the location of the ureteral orifice in the bladder. So in performing your transvesical ureteral ostomy, the goal is to replicate the normal intramural ureteral anatomy and creating a more longitudinally oriented intramural to submucosal tunnel. So when the orifice is located in an orthotopic position or in its normal position, then the Intraextravesical or the Politano Leadbetter technique is ideal. For orifices ectopically positioned in a more cephalad position or mas mataas, you perform the ureteral advancement or the Glenn Anderson technique. Now, for extremely laterally ectopic positions, the Transtrigonal or the Cohen technique is warranted. So as you can see, for A and B, we have the orthotopic position. So the intra-extravesical or the Politano Leadbetter technique was performed. For C and D, you have a more cephalad position. So the ureteral advancement technique was performed. And for E and F, you have a more lateral, or it's very lateral. The orifices are very lateral. So the Transtrigonal technique was performed. Now for the extravesical transvesical ureteroneocystostomy techniques. So first is the extravesical tunnel or the open Lich-Gregoir technique. So the incision and the dissection of the bladder and ureter are similar as your intravesical techniques. Excuse me, wait lang. Then you isolate and tag the ureter and free the posterolateral bladder wall. Then you dissect the ureter caudally towards the bladder hiatus. Once at the bladder, you incise the detrusor muscle along the intended path of your submucosal tunnel with cautery. You continue your dissection until you're outside of your Waldeyer sheath, which grossly appears as a translucent bluish layer. And then you dissect the detrusor flaps from the urothelium perpendicular to the submucosal tunnel. Any violation of your urothelium can be repaired with chromic 5-0 figure of 8 sutures. And then you lay the ureter into the tunnel and close the detrusor muscle with the Vicryl 2-0 interrupted sutures. And so you perform extravesical dissection of your ureter, and then you lay it inside and then you close it. So now next is the external tunnel or the Boari technique, which is used in renal transplantation. Wait lang. Yan. Okay. It uses the same approach as the Lich-Gregoir, and then you place a traction suture cephalad and medial to the intended site of your reanastomosis. However, what's different in this technique is you make 2 centimeter full thickness transverse incisions, 3 cm apart on the dome of the bladder. And then you pass a right angle clamp in the submucosal space between the 2 incisions. You spread the clamp to the full 2 cm width of the incisions, and you incise the mucosa of the caudal incision sharply. So these are the 2 incisions, and then he inserts a right angle clamp in the mucosal layer between the 2, and then there is sharp dissection of the more caudal incision. And then you perform spatulation of the ureter, and you pass it from the cephalad to the caudal incision. You then place Vicryl 4-0 sutures approximating the ureter to the urothelium at the apex and at the 3 o'clock and 9 o'clock positions. You then place a horizontal mattress suture at the 12 o'clock position through the full thickness of the bladder. And you close your incisions with the Vicryl 3-0 simple interrupted sutures. Next is the Detrussorrhaphy, or the Hodgson Firlit-Zaontz technique. So in this technique, you incise the seromuscular layers of the bladder following the course of the ureter down to the submucosa, but still remaining outside of your Waldeyer sheath. And then you perform dissection of the submucosa from the detrusor circumferentially around the ureteral orifice. And then you place 2 Vicryl 4-0 sutures through the seromuscular layers of the bladder and the ureter. You begin at the 5 o'clock position, you pass the suture through the ureter and then the bladder, caudal to cephalad. You pass the suture through the seromuscular layers of the bladder near the site of entry to produce a mattress type of vest suture. You repeat this process at the 7 o'clock position. And then you close the Detrusor layer over the ureter with Vicryl 3O sutures. Next is the Intravesical or the Paquin technique, which is similar to the Extravesical approach. So in this technique, you ligate the ureter just outside the bladder and divide it from the bladder with electrocautery. You then make an oblique cystostomy, beginning just anterior to the dome of the bladder and on the side of your reimplantation. You extend the incision posteriorly to the neo-hiatus, and then you develop a submucosal tunnel towards your original ureteral orifice. You then perform your ureterovesical anastomosis by approximating the transmural ureteral tissue with a urothelial bladder using Vicryl 5O interrupted sutures. Now, for discussing the whole of ureteral cystostomy, we will now discuss the post-operative problems encountered with these procedures. So first is obstruction. Obstruction after ureteral cystostomy presents as oliguria, anuria, flank pain, acute abdominal pain, nausea, vomiting, prolonged ileus, and sepsis. Most oftenly, it is caused by edema, but it can also be caused by bladder spasms, intramural or submucosal hematomas, ureteral kinking, or twisting. It is diagnosed initially with ultrasonography, and for the most part, it can be managed conservatively, as most cases are transient. For example, you can manage your oliguria and anuria with fluid boluses. However, the presence of an obstruction, drainage can be done with stenting or percutaneous insertion of a nephrostomy tube. NT is preferred, of course, as it allows for antegrade nephrostogram. And, of course, performing endoscopic procedures after your ureteral neocystostomy will be technically very difficult. Drainage is mandatory in sepsis. And for obstruction persisting beyond 3 weeks, they occur most oftenly from ureteral angulation or kinking, ureteral twist, ischemia, or extravesical scar tissue. Kinking occurs when your neo-hiatus is too high or too lateral. The high reimplant phenomenon is when the neo-hiatus is too high or too lateral, and your ureteral drainage resolves when the bladder is empty. Ischemia is produced by aggressive ureteral dissection or a too tight neo-hiatus, or again a ureteral twist, which leads to stricture formation. Ischemia at the orifice usually is located or begins at the apex of the spatulation. This can be treated by endoscopic dilation or incision of your ureteral roof. Extravesical scarring causes extrinsic obstruction and requires reoperation. Another complication or post-operative problem encountered with these surgeries is persistent or recurrent vesicoureteral reflux. VUR for up to 3 months be observed while your post-surgical inflammation resolves, and the majority does resolve. However, if your VUR persists after 3 months, so these might be the cases why they don't resolve after 3 months. They happen if the length of your submucosal tunnel is inadequate for the diameter of your reimplanted ureter, or in short, you have a short tunnel or there's insufficient tapering. It can also occur when the ureter retracts secondary to a poor fixation to your orifice, and these will require reoperation. Another problem encountered with ureteral neocystostomy is a contralateral VUR, which occurs in 3 to 18% of cases. This is the most common problem encountered in unilateral ureteral neocystostomies, and they are more common with higher grades of reflux pre-operatively. This may be a result of failure to be detected pre-operatively, but usually they are managed conservatively. Now, we've said before, if the obstruction does not, and the vesico-ureteral reflux does not resolve spontaneously, then you decide to reoperate. So, reoperative ureteroneocystostomy is warranted. So, of course, you decide to do this once you have eliminated secondary causes of recurrent or persistent VUR. So you have the option to perform endoscopic management or reoperative ureteroneocystostomy. The success rate for recurrent VUR as an indication is higher as opposed to performing your reoperation for obstruction. So for reoperation, it is technically more difficult. And as I mentioned before, you have to strictly adhere to the following principles. So adequate ureteral mobilization without skeletonizing the blood supply, posterior hiatus positioning, submucosal tunnel to a ureteral diameter ratio of at least 5:1, and a ureteral course that avoids tension, does not twist, angulate, or kinks. These cases require long-term follow-up as delayed obstruction can develop as late as 10 years post-surgery. Additionally, during the operation, you will encounter shortened ureters, which will pose another challenge aside from their fibrosis and inflammation. So in these cases, you can opt to do a psoas hitch, although those are for unilateral implantations, with or without a Boari flap. For bilaterally shortened ureters, you can perform the transureterostomy combined with a psoas hitch or a Boari flap to maximize the length. In extremely shortened ureters, ureteral substitution with a colon or ileum segment reconfigured as a Monty channel can also be effective. Okay, as I discussed, as I mentioned earlier, I will then discuss the psoas hitch. So the psoas hitch is utilized to bring the bladder cephalad enough and anchoring it to the psoas muscle to allow for a tension-free anastomosis with a healthy ureteral segment. It is used to an injury to the distal third of the ureter precludes a direct re-implant. A contraindication to doing the psoas hitch is a small volume bladder, or bladders exposed to previous pelvic radiation or surgery may have a compromised blood supply. Urine leakage is the most common complication for the psoas hitch, and it follows similar follow-ups to the ureterostomies. Relative to the Boari flap, which I will discuss later, the advantages of the psoas hitch is an increased technical simplicity and decreased vascular compromise and voiding difficulties. So, in addition to your usual preoperative planning, you also should perform, for patients who will undergo the psoas hitch, is evaluation of the bladder function and capacity. As well, and then if you find out that the patient has bladder outlet obstruction or neurogenic dysfunction, you should address those preoperatively prior to performing your psoas hitch. So, surgical incision and ureteral access is essentially same as your ureterostomy. And once you have identified the ureter, you place a vessel loop around your ureter. You continue your dissection to the level of your obstruction, and you transect the ureter proximal to the defect and place a stase suture. You then ligate the distal ureteral stump with an absorbable suture. Onto the bladder, you mobilize the bladder on the side ipsilateral to the ureteral pathology. You pull the ipsilateral bladder dome cephalad and position it over the psoas muscle above the bifurcation of the common iliac. And then you place the adjacent to it the transected ureteral segment to check if it will allow for a tension-free anastomosis. So first, you perform a transverse to oblique cystostomy on the posterior bladder dome, ipsilateral to the side of your defect. You then pull the bladder dome cephalad to the ipsilateral psoas muscle, and you suture the posterior wall of your bladder to the psoas minor muscle. So you perform your psoas hitch by putting 3 to 5 slowly absorbing sutures, preferably Vicryl 2O, into the bladder muscle, but not the mucosa, and then into the psoas minor muscle. Your suture should be placed superficially through the tendon and parallel to the direction of the muscle fibers to minimize risk to the genitofemoral nerve. To minimize risk for genitofemoral nerve injury. Okay, so after you have done your cystostomy and you have performed your psoas hitch, a tunneled ureteral anastomosis can then be created by submucosal dissection toward the neo orifice. So you deliver your ureter through the submucosal tunnel into the bladder, and once delivered, you spatulate your ureter anteriorly and you anastomose it to the neo orifice using interrupted sutures. You deliver the ureter at the superior lateral aspect of the bladder because in that region it is less mobile than the lateral bladder and it allows for a straight ureteral course. You perform your anastomosis with interrupting 4 to 6 Vicryl 4O sutures. And you may also loosely anchor the ureter at the extravesical surface of your bladder at its point of entry. So for closure, you place first a ureteral stent and you perform a 2-layer closure of the bladder, starting with a mucosal layer, and then you close your muscle layer. For drainage, a urethral catheter is sufficient. In cases with hematuria, a tenuous bladder closure or a tenuous bladder closure, you may insert a suprapubic tube. And you may also leave a drain for post-operative monitoring. Next, the Boari flap. The Boari flap is employed when the pathologic ureteral segment is too long or ureteral mobility is too limited to perform ureteral neocystostomy. It bridges a 10 to 15 cm ureteral defect and can even reach the renal pelvis in some circumstances, especially on the right side. The most common complication of this procedure is recurrent stricture formation resulting from ischemia or excessive tension on the anastomosis. There have been also reports of pseudodiverticulum. And then your preoperative evaluation for the Boari flap is similar to the psoas hitch, wherein a small bladder capacity can be associated with an inadequate Boari flap creation. The patient is positioned supine. You should, of course, insert an IFC to facilitate intraoperative bladder filling, and your incision is a subumbilical midline or a fan and steel incision. So after your incision, you continue your extraperitoneal dissection to expose your proximal ureter. You expose your ureter proximal to the defect above the bifurcation of the common iliac artery. You then tag the ureter with a vessel loop and dissect until your defect is reached. In cases with significant ureteral scarring, an intraperitoneal approach is ideal to minimize the risk for injury to the iliac vein. So once you have excised the diseased portion of your ureter, you place a stay suture on that distal end of the healthy ureter. As for the bladder, you fully mobilize the bladder on the posterior wall and the contralateral side of the affected ureter. This may entail division of the superior vesical pedicle, and it will be easier if you distend the bladder during this process. You then measure the distance from the posterior bladder wall to the cut end of your healthy ureter. So for the creation of your Boari flap, the Boari flap should at least be 4 cm wide at the base, 3 centimeters at the tip, or at least 3 times the ureteral diameter. The length of the flap should equal the length of the defect plus an additional 3 to 4 cm. The ratio of the flap length to base width should not be greater than 3 to 1. Otherwise, flap ischemia might occur. And then you place stay sutures on the 4 corners of your designed flap. So on cutting current, you incise the bladder wall across the distal narrow side of the flap. You pass a feeding tube into the contralateral ureter to avoid injury to that ureter during closure. So again, the bladder flap should at least overlap the ureter by at least 3 centimeters to allow for a proper submucosal tunnel. So in doing this, you may mobilize the ureter, even mobilize the kidney if necessary. And then you create a 3 centimeter submucosal tunnel with Metzenbaum scissors, and then bring the ureter through with a French 8 feeding tube. Once you have inserted your ureter into the bladder, you spatulate the ureter obliquely, and then you fix the superior end of the Boari flap to the psoas minor muscle using a Vicryl 3/0 suture, but of course being careful of the genitofemoral and the ilioinguinal nerves. And then you tack a Vicryl 4/0 suture to the apex of the ureter and the full thickness bladder wall. You then perform your anastomosis with interrupting Vicryl 4/0 sutures. So in closing, you place a stent, you place a closed suction drain, and maintain your IFC. You can also remove the contralateral feeding tube prior to your bladder closure. So you close the superior end of your flap with Vicryl 4/0 interrupted sutures, Vicryl 4/0 running for your mucosa, and Vicryl 3/0 for interrupted muscle and adventitia. The peritoneum can also be mobilized for an additional layer. So for the postoperative care for your patients who have undergone psoas hitch in the Boari flap, a cystogram should be performed 10 days or longer for confirmation of the integrity of your bladder before stent removal. Anticholinergics may be given 1 to 2 days before that cystogram. End.
Thank you for that lecture. So do you have any questions for our speaker? You can turn on the mic or put your question at the chat box.
Rome, yung kanina, yung reimplantation, yung 5:1?
Yes, sir.
O 5:1 ng diameter ng orifice sa length, hindi rin sa diameter ng mucosa, ha? Sa length ng submucosal. Oo.
Yes, sir. Apa. Okay,
Hindi,
sir.
kasi hindi, baka typo lang naman yung tayo.
Yes, sir. Yes, sir.
But it's
Thank you, sir.
the orifice, the length. So pag masyadong malaki, mega ureter, then you might have to do tapering technique.
Okay, sir.
Okay,
Thank you,
without
sir.
devascularizing. Or pwede yung linulubog mo lang, no?
Yes, sir.
Alright. Yun naman yun.
Thank you.
Thank you. Thank you.
Thank you, sir.
Ako, may comment lang ako.
Yes, sir.
Okay, whatever repair you do, the most important thing is check for any tension.
Yes, sir.
Kasi kahit anong ganda yung operasyon mo, basta may tension, that's where you will decide if it's a reimplant, will you do a hitch, will you do a Boari flap, can you still tunnel, will it be intravesical submucosal, will it be extravesical? The decision will be based on the tension. Intraoperatively, ang ginagawa ko personally, I will, pag hindi ko pa siya pinipermanent, pero titinan ko pag full bladder at pag kinolaps mo, more or less. Siyempre, hindi naman sarado yun. Pero titinan mo yung plane ng ureter. Pag may duda ka doon sa tension, mukhang, again, you progress to, again, it's either a reimplant, a hitch, a Boari, and well, hindi ka naman, usually, you are prepared if you want to do an ileal interposition or a transureterostomy. Kasi I've seen one already na nag-repair siya ng transu pero may tension. So nag-fail lang yung operation. Napunta sa akin yung morbidity done by another surgeon. So lesson learned there is in the first place, there should not be any tension. Kasi kahit na anong ganda ng repair mo, kung may tension, wala din. It's just a comment. Okay? Kasi you were all discussing about techniques.
Thank you, sir.
Ang sa akin lang is there is also importance in First, the viability of the edges of your ureter, which if you discuss also where is the arterial supply of the distal third as compared to the arterial supply of your proximal and middle are different. So whereas preferably do not suture at that point, viability of the ureter, tension level, these are the key points during, finer points na lang. I understand that technique is there. Pero yung mga kasi kahit naman magkamali ka sa technique, apparently, ang tinuturo nga, chromic 5-0. I've never used a chromic 5-0. I've always used chromic 4-0, chromic 3-0, Vicryl 3-0. But again, that's in the book. So, technique, pero yung basic is no tension, viable edges, and yung ako hindi rin ako masyado nagko-cautery ng bladder at ng ureter kasi the more you cauterize, the more the edges are dead. Dead tissue yan. So ako, pag nagka-cut ako usually, hindi ako masyado nagko-cautery. Personally, But again, the book says cautery, but again, be cautious. Kasi like sa hypospadias, pag gumamit ka ng cautery, sira lahat ng tissue mo. So, yung concepts lang. And this is a comment. Okay.
Thank you, sir.
So if we do not have any more comments, we'll just take one picture for the attendance. And then our next I think we'll have a meeting this Monday regarding some of our policies. So Ryan, can everyone turn on the picture or a photo? Okay, gonna. Brown out sa inyo. Dilim dyan na.
Dilim dyan na.
Brownout pa rin sa inyo, Lenin?
Brownout pa eh.
Parang kinarat ni hindi
Hindi nga daw eh. Sa amin brownout pa eh.
Oo, yung mga mga sa village yun yata, hindi nagbabayad ng kuryente.
Okay, ready everyone?
Okay.
Ang dilim talaga kaya Dr. Lenny, no? Salamin lang nakikita.
Yan na lang. Ganun na lang. Para...
Okay, so see you.
Okay.
Thank you po.